Okay, good afternoon. Thank you very much for the invitation. Thank you very much, Dr. Deepak sir, for the introduction. So my topic given to me is regarding the transforaminal epidural steroid injection. And since morning, I think we've already seen the many injections, that is the transforaminal epidural steroid injections, facet injection and all. So we'll just discuss about the technique and how basically executing this transforaminal injections in a patient with a back pain or a disc herniation. So if you consider, obviously, this the lumbar radicular pain or radiculopathy is very commonly encountered complaint, and most of the things that the patient goes to a neurosurgeon, a neurologist, a orthopedician, pain physician. So the patient's load, if you say the low back incidence is very high. So obviously somehow the patient has multiple types of pathology that leads to a low backache. And one of the things is that the herniated disc, because of the foraminal stenosis, is one of the most common cause that lead to basically inflammation or irritation of the spinal nerves or the dorsal root ganglia. So the disc herniation basically causes something, changes in that area that causes pain. So why there is pain basically? Is it only the compression alone that does cause the pain or something else? Because if you've seen, suppose a surgery has gone, the patient normally suppose disc surgery and all, in the post-operative most of the numbness or something is there, not like the pain. So in this case, disc herniation basically, it's not only the compression, it's only the inflammatory reaction that is going on around the nerve roots. So the highly inflammatory material that is present in the nucleus pulposus, basically with the first letter is A2 or nitric oxide metal proteases. So when there is disc is disrupted, this material that is there just come out of there and deposited around the neural structures, and they just elicit a neural or chemical inflammation that leads to pain or intense pain. And if it is going along the nerve root, that becomes a radicular pain in the patients. Intralaminal corticosteroid, the patient when they go for the conservative treatment, then obviously the patient is offered your interlaminar corticosteroid, and if it's the interlaminar corticosteroid means the steroid is deposited in the dorsal part of the epidural space, or the posterior part. That sometimes fails to reach the segmental nerve radius, because if you see the disc is the more ventrally, and obviously the herniation that is coming and involving, that is the more ventral part. So if the drug is deposited in the posterior part, sometimes the drug may not reach to the target area. And if a nerve is getting irritated, it's ideal to deposit the drug close to the nerve. So that's why, in this case, the transforaminal corticosteroid injection is done, so that the drug should be very much close to the involved nerve root and in the foraminal area, you can see the nerve root is getting affected, and this is the area that basically we want our drug to reach. So if you see the drug is, this material is herniated out from here, and it involves a chemical inflammation at this area. So our just motto is to reach the drug at this part. Even if you see the lumbar epidural of this disc, in the case of disc herniation also is a very good level of evidence in case of transforaminal injection in such cases as a conservative treatment, the first before at least in the surgery. In MRI also you can see before, so you can see the different your hernial disc is bulges there involving the transversing root and exiting nerve root. You can see there's a disc bulges there, and obviously this is the area where the DRG is getting compressed sometimes. In this case, it is just a disc is bulged. So that means even if you see it is not causing a mechanical compression, but still the disc has that's hydration is lost. That means a normal disc, if you see the annual purposes is white, but in this case it is black. That means the disc desiccation and the disc is bulged. So that causes inflammation. So even if there is significant compression is not there, but still there is a chemical inflammation that is irritating the nerve and the DRG. So the traversing roots is also in this case free, but that is the area that the lateral recess and exiting root area that your disc material can involve, and that causes inflammation. In this case, if you see in the left side, you can see a significant disc bulge is there, disc herniation is there, just irritating the nerve. That in this case, if you are finding such cases in my pain clinic, obviously we can post this patient as transforaminal steroid injection. If you see it may not be a significant caudal compression or thecal compressions, that is the patient doesn't have any, but the pain is very severe. So the patient in this area, the fit is the criteria that you might go for a transforaminal injection, and patient will very good relief in this case. So before patient will have subsequently cauda or some motor involvement. So let us see the technical part basically. How basically you can execute or reach this part, if you say a middle or in this case. So if you see the foraminal part, if you see from lateral side, you can see these are the formed by the pedicle, above one, the upper one, and the down one in this case. Then the posterior you can see the your supraarticular process and infraarticular process above and superior below. And also in the front side you can see the lower the body and the disc in the front. This is the area you can see your nerves exiting route is there, and this part is occupied, or if the disc is herniating, that part is involved, and that is where you are going to reach. So what is the content of the this foramen basically? It's not only the root and this there. Along with the root, it's also there the vein, the fat tissue is there, and the artery or some reticular arteries are also there in this case. That's why sometimes it is very, you have to be very cautious when giving the transforaminal injection. If you have to be very careful not to injure any artery, or if you are using a steroid, a particular steroid, make sure the drug should not go enter into your artery or clogging your blood vessels. So next is how to proceed in this case. Any procedure is obviously the informed consent is very important in the patient who is undergoing a transforaminal injection, because the injection or needle is very close to the nerve. So obviously the patient should be aware of that. There might be nerve injury, sometimes patient has pain. So you are putting it really close enough, suppose the patient moves or something, the inadvertent needle is inside, then nerve injuries might occur. You are depositing steroids. So there are so many steroids are available. That is the particulate, non-particulate. So there are also complications related to the steroid also. Obviously then infection is another chance that if you are not take the proper sepsis. The checklist must be, obviously you can take the history of allergy, because you are also using a local anesthetic for the skin infiltration, for also the drug. Coagulation studies sometimes very important if the patient is having some blood thinners like antiplatelet or anticoagulant. In that case, you have to strictly follow the guidelines as per your American Society of Regional Anesthesia or Pain Intervention, and also there is single society that have given the guidelines that the drug should be stopped as per your standard guideline. In some cases, the patient has suppose cardiac origin and taking some medication, then obviously you take the physician opinion also regarding the stoppage of the medications in those cases. Is there any contraindication? Yes, obviously the uncooperative patient, sometimes it's difficult, you might abandon if the patient is not cooperative properly, because normally you don't go for a general anesthesia for such injections. Bleeding diathesis, coagulation or abnormalities, local set infections. There might be some of the relative contraindications, sometimes it's technically difficulty if the patient has had severe degenerative disease or a large disc displacement, or sometimes a facet hypertrophy. So the needle steering might be sometimes difficult in those cases. So let's come to the floor anatomy. Obviously, I think the injection has been very well described by Dr. Ashish and I think the research. So let us again just revise this how floor anatomy that normally in this case we see for or look for. The first thing that we are going to do of step one is the true AP view of the total body. And the lower, and in this case transfer in the injections we do a squaring of the plate, that is the lower end plate squaring. That means this is the first is the true AP means that it's maintain the symmetricity, that both the pedicle is equidistant from the midline. That the first, that is true AP we are going to do. Then we are going to look for your inferior end plate squaring. That means it should be, if it is not squared along that, it might be in the oval shape. So you make it a one line so that the inferior end plate is properly square. Then you can look for the circular shadow on the lateral side where the pedicle that gives a shadow like this, and obviously there's faintly you can see the transverse process. So this is the area that we are going to see for. Now once you do a AP view, then subsequent second injection is once you mark the which nerve we are targeting. Depending on that, then you go for ipsilateral oblique. So the same side you are doing now, or the patient is going to have this oblique in this case. So what I'm going to see in this case once you do oblique. So in this case, we normally a very good description of the Scotty dog. That means if you make image like this, you can identify basically different structures accordingly if the anatomy is good enough. So if the supraarticular facet can be identified as your ear of the top, transverse process which is node, and the eye that normally the Dr. Debesh also described as a medial branch or the medial nerve. Pedicule, you can see that infraarticular facet of the hand, the forelimb, and hind limb is the ear pars. So this basically we make this image first so that we can identify which type of injection we are going to do it. And the transforaminal injection, the injection area is normally just below the mouth of that area. Now let's come to the ones who identify this, there are the different approaches. So what are the different approaches for the transforaminal injections? If you know, there are normally 3 approaches. There is a safe triangle approach, a supramural approach, that means the injection is above that, retromural, and the inframural or Camden's triangle approach. So if in this case you see, once you do a gauge open like this and the nerve root in this foramen, you can see the first is the subpedicule, just below the pedicule, that is above your nerve root, that is the supramural injections. Second is the retromural, if just the needle is just on the posterior side of the nerve, that's the retromural injections, and the lower one is the retrodiscal or we do normally for transforaminal drug preparation in this case. So let's come to the safe triangle. It is a misnomer, it is not really a safe triangle, but still the name per se, how the safe triangle is made, or normally in this case made. If you see in that approach, one line is going to the subpedicular line, the one line parallel line, another line in the lateral border of your pedicule, that is one line, and the hypotenuse angle is formed by the nerve root itself. So this triangle, once it is formed, this is go at this 6 o'clock position of the pedicule. That normally our target point for a transforaminal injection. So once you have scotty dog appearance, we make this triangle and then go just exactly at the 6 o'clock position of this pedicule. That is the safe triangle approach in this case. So in this case, basically we are not injuring or try to avoid from the nerve root. That's what is a safe. But this is again, if you are not vigilant, this is the area that the blood vessels are there. So that's why it is not really safe in sometimes if you are not taking precautions in this case. Second is the Camden's triangle. Obviously, this inframural in this case. You can see the disc is there. So the medial border is formed by the vertebral end plate and the vertebral border. Then the lower with the over the pedicular line, and there's another your hypotenuse third border is formed by the nerve root itself. So this is basically the same approach normally we do for your disc injection, something like that. The same exactly this position is done for the disc injection or any disc procedure is done. So that's why this approach sometimes have the risk of entering into the disc in these cases. So this in this case this is yes sir. So again, I just regard the safety concern because there are so many blood vessels and the your medullary arteries there in this case, so that's why it is a little bit riskier. And one of these your artery of identicus, the anterior radicular medullary artery, that's normally if it is injured, that may cause hematoma, or sometimes here the steroid is entered. In this case, that may lead to infarction that is very grave, may lead to paraplegia in such cases. So needle entry, obviously, as I described, look at the 6 o'clock position. You can see the Scotty dog at the just below the head. That's the entry point in this case. And this, once you're in the epiview, you can see the needle. Then you confirm your needle in the lateral view. Once in the lateral view, you can see the needle position in the foramen. You can see the needle is exactly in the superior, dorsal superior part of the foramen. That is if you're doing a safe triangle approach. So once you do that, then you can see. Look for the dye and then look for the dye spread in this case. So the final deposition like that. In case of a Camden's triangle, this is the supraarticular process, and in this case, a needle entry just retrodiscal and just lateral to the supraarticular process in this case. So this is the entry point, just right or lateral to the supraarticular process in this case. So here basically we are entering the lower part of the foramen. This is that's why it is the infraneural, and mostly sometimes if you are doing an infraneural injection, it also involves the traversing routes also. So that the supraneural is mostly involved in your exiting route. So another again, sometimes you do a vertebral bend, so that is sometimes if there is less space, and some little steering also help in this case. Just setting the transverse process in the pedicule and just steer towards your foramen. You have to be very careful because sometimes the patient might be jump hitting injection, the immediately you drop because you might be hitting the nerve root in that case. So that to avoid any sort of movement or any kind of abuse. Next, the dye spread is very important. Once you finally position, you can, after putting the dye, the dye should be spread around the medial border of the pedicle, and if you just look for the volume, how much you need for that sitting at the medial skin, and also the drug is going to the epidural space. If you give more volume, obviously the epidural space will spread will be there. So this is the ideal spread of the drug. So is there any other spread that can be, you have to be careful obviously, because in this case DSA is there, so you can see around the medial side of the pedicle this drug is spread. There might be some of the aberrant spread also, suppose an arterial spread or a venous septic. In this case, if you see the drug is midline to the AP view, like this is the arterial spread. Sometimes if you are doing an extradural or disc is there in the foramen, that is the actual disc is there, so that might sometimes you can take a picture of like this. That means there is significant disc material that has been extruded in this case, and the dye spread is going to the disc also. So this type of spread sometimes you can see also. Subdurals, obviously in this again there is a chance by the subdural dye spread also. In this case the dye is more stick appearance like this in the posterior side. The homogeneous spread, in case of the epidural spread, there will be air pockets will be there, but in this case it is a homogeneous posteriorly in this case. This is the intrathecal spread. You can see the intraneural injection has been occurring in this case. You can see the ventral thecal sac in this case like this. Okay, yes. Again, once you depot the drug, might be obviously selection depending on this. This dexamethasone is very safe because it is a non-particulate steroid in this case. Recovery, obviously, after recurrence, if you are using a local anesthetic, most of the patients recover well. If not, then obviously you have to recon the diagnosis. Here the complication that is very important because a paraplegia has been documented few case reports in this case, but it's not only the particular steroid. Sometimes even the severe disc compression is there. Even slightest transforaminal drug deposition might sometimes aggravate the situation, and in this case, even if there is no infarction, this is basically the patient also land up in paraplegia. So they basically have to be careful. So obviously the summary to transforaminal, this is again you can think of this transforaminal injection before going for surgical intervention as a very good treatment modality in such cases. Thank you. Sorry.
I think time is up.